Management of acute bacterial meningitis in children. Mainly, we'll talk on antibiotic therapy, duration of antibiotic therapy, corticosteroids, and the supportive care. The first is antibiotic therapy. The initial or empirical choice of antibiotic till CSF fluid culture and blood culture and sensitivity arrives for meningitis in infants and children should have the following three characteristics. Those empirical antibiotic choice should have the following three characteristics. Those characteristics include being bactericida, having a good blood-brain barrier penetration effect, and being excellent against the typical bacterial cause of meningitis. Mainly the three typical cause of bacterial meningitis: Neisseria meningitis, strep pneumonia, and Haemophilus influenza type B. This is till CSF fluid and the blood culture and the sensitivity arrives. So that is why we say empirical choice of antibiotics. When we see the three common causes of bacterial meningitis with their antibiotic sensitivity, the first is strep pneumonia. 25 to 50% of strains are resistant to penicillin, and 25% of strains are resistant to third and the fourth generation cephalosporin, but they are sensitive to vancomycin. The second is Neisseria meningitis. Most strains are sensitive to penicillin and the cephalosporins, and the third one is H. influenza type B. Approximately 30 to 40% of isolates produce beta-lactamase and therefore are resistant to ampicillin. These beta-lactamase producing strains remain sensitive to third and the fourth generation cephalosporin. So, the recommended empirical antibiotic regimen in suspected cause of meningitis outside the neonatal period is vancomycin combined with the third generation cephalosporin. Vancomycin is just to cover the beta-lactamase strains of strep pneumonia. So we can give ceftriaxone with vancomycin or cefotaxime with vancomycin till culture and sensitivity arrives. Delay in initiating antibiotic therapy, even at the level of few hours, are significantly associated with adverse clinical outcomes and deaths. Even if there are contraindications to lumbar puncture, antibiotics should be given prior to obtaining a head CT scan and a lumbar puncture. Patients allergic to penicillin or cephalosporin antibiotics can be treated with meropenem. If Listeria monocytogenes infection is suspected, as young infants or those with a T lymphocyte deficiency, ampicillin is also should be given because cephalosporins are inactive against Listeria monocytogenes. If a patient is immunocompromised and gram-negative bacterial meningitis is suspected, initial therapy might include cefepime or meropenem. The other is about duration of antibiotics. Currently, the recommended treatment duration for uncomplicated strep pneumonia meningitis is 10 to 14 days. For Neisseria meningitis, 5 to 7 days, and for H. influenza type meningitis, 7 to 10 days. Gram-negative bacillary meningitis should be treated for 3 weeks. Patients who receive pure IV antibiotics prior to LP and they do not have an identified pathogen or partially treated meningitis, but do not have evidence of bacterial meningitis based on their CS profile should receive therapy with ceftriaxone or cefotaxime for 7 to 10 days. So, those who are diagnosed to have bacterial meningitis, partially treated bacterial meningitis based on their CSF profile, but we didn't identify the causative pathogen, we should have to give ceftriaxone or cefotaxime for 7 to 10 days. The third one is about corticosteroids. Rapid killing of bacteria and CSF effectively sterilizes the meningeal infection, but releases toxic cell products after cell lysis that precipitates the cytokine-mediated inflammatory cascade. The resultant edema formation and the neutrophilic infiltration might produce additional neurologic injury with worsening of CNS signs and symptoms. Therefore, agents that limit production of inflammatory mediators could be of benefit in bacterial meningitis. So, IV dexamethasone 0.15 mg per kg per dose given every 6 hours for 2 days is effective if given with or soon after the first dose of antibiotics. It is mainly effective for strep pneumonia and H influenza type B. The fourth one is supportive care. Serious life-threatening complications of acute bacterial meningitis often occur in the first 2 to 3 days. Therefore, patients should be cared for in intensive care setting to assure close monitoring. Also, we should have to prevent and treat SIDH, prevent and treat ICP, and the management of seizure, and also fluid and electrolyte management in a child with acute bacterial meningitis. This is all about management of acute bacterial meningitis in children. Thank you for watching.